Hello everyone. Today I'm going to talk about the pituitary cancer. My name is Chen Ying. Here is the content page of my presentation. The pituitary gland is a small pea-sized organ in the brain. It is located behind the back of the nose. It can make hormones that affect many other endocrine glands and function in our bodies. The patient is a 68 years old male who is diagnosed with pituitary adenoma. If there is a pituitary tumor, it may affect our normal hormone production. Pituitary tumors are usually benign and rarely malignant, so the tumor can be classified by specific hormone. For example, adrenocorticotropic hormone, prolactin, growth hormone, and thyroid-stimulating hormone. However, the case report haven't stated the type of the pituitary cancer of the patient. In 1997 and 2000, the patient had received resection of the pituitary tumor. In 2002, the tumor progressed again and the patient had received radical external beam radiation therapy. 5 years later, the patient presented with deteriorating vision in his right eye, and the MRI scan showed a compression of the optic chiasm by a suprasellar mass. So he further undergo hyperfractionated IMRT. In the following years, the patient subsequently followed up with serial MRI scan. In 2017, the MRI showed an enhancing mass in the left suprasellar cistern and the floor of the fourth ventricle. So the patient undergo craniotomy and stereotactic radiation therapy. After 6 weeks of the completion of the treatment, the patient passed away. For the signs and symptoms of pituitary cancer, it usually varies by the tumor extension and the specific hormone affected. The patient had experienced ongoing headache and deteriorating vision because of the compression of optic chiasm. Other possible signs and symptoms can be affected by specific hormone. They can be less frequent or no menstruation in women, growth of breast tissue in men, and slower growth and sexual development in children. For the surgery in 1997 and 2000, as the details are not mentioned in the case report, so the information below are the general conditions in pituitary cancer. Surgery is usually a first-line treatment to remove the tumor and relieve the compression of mass to the surrounding tissue, such as ventricle, brainstem, and optic chiasm. A common surgery can be transsphenoidal surgery and craniotomy. For the radiotherapy in 2002 and 2007, the case report had only mentioned the prescription. For the radical external beam radiotherapy in 2002, it gives 1.8 gray per fraction daily to total 45 gray in 25 fractions. In 2007, the radiotherapy gives 1.2 gray per fraction twice daily to total 50.4 gray in 42 fractions. As it is a hyperfractionated radiotherapy, the toxicity to the normal tissue may be adverse. In 2017, the serial MRI scan showed an enhancing mass in the left suprasellar cistern and the floor of the fourth ventricle. As shown in the figure, the right arrow indicates the mass of the pituitary cancer. Also, the staging CT tab and MRI spine show no distant metastasis. After the investigation, the patient had received the midline suboccipital craniotomy to remove the entire tumor. During the operation, the tumor was found to be stuck to the posterior brainstem and extended beyond the cellular region to involve the fourth ventricle. In the histology report, It shows cells with high MLB1 proliferation index and positive for chromogranin. The MLB1 proliferation index usually associated with poor prognosis. And the chromogranin usually indicate the presence of neuroendocrine tumors. For the treatment planning, the multidisciplinary team had discussed about the previous treatment in 2002 and 2007. Considering the toxicity to the critical organs, they decided to proceed a fractionated stereotactic radiotherapy with a 5-fraction treatment regimen. It can provide better accuracy and lower the toxicity to the optic chiasm. Also, planning using fusion of CT scan and MRI scan can provide better tissue contrast to localize the tumor and organ at risk. The stereotactic radiotherapy gives 5 gray perfection to the 80% isodose line to total 25 gray in 5 days. So the possible immobilization device should be a non-invasive head frame. Here is a reference image showing the head frame. For the conclusion, as demonstrated by the case, pituitary carcinoma are characterized by locally invasive to the optic chiasm and ventricle, and multiple recurrence with limited therapeutic options. The management of pituitary carcinoma is mainly palliative, and it is hard to be cured. The treatment may not significantly prolong the survival to any major extent. Other treatment modality can be gamma knife. The gamma knife radiosurgery delivers focused radiation beam using cobalt-60 to a variety of tumor and lesions in the brain. It's good at delivering radiation with very steep fall-off. The optic chiasm and optic nerve can be spared. It also exposes a much smaller amount of brain to the radiation, so it can lower the risk. However, large pituitary tumor and tumor too close to the optic chiasm are not advised to do the gamma knife radiosurgery because of the risk of the damage to vision. Although gamma knife radiosurgery showed precise radiation delivery on the tumor and good sparing of surrounding organs, it may not be suitable to the patient. Because the tumor was large and close to the brainstem and the fourth ventricle. Also, considering the previous treatment, the optic chiasm may not able to tolerate the 1-fraction radiosurgery. As the side effects are not stated in the case report, I have found some possible side effects. They can be classified into mild effects and adverse effects. Mild effects include nausea, fatigue, and hair loss. Adverse effects like hypopituitarism may require replacement of hormone for the rest of life. Also, loss of vision may occur if the radiation have damaged the optic chiasm. Secondary brain tumors may also occur. For the prognosis, it depends on 3 main factors. They are tumor size and invasion, hormone production, and metastasis. Large tumor may be difficult to reset and press the surrounding tissue. Also, hormone-producing tumor continue to make too much hormone, and the effect may be difficult to reverse. The tumor spread to the central nervous system and other regions also give poor prognosis. This is the end of my presentation. Thank you. And here is the reference list.